we've had a great discussion today, and the last topic of discussion will be on emerging concepts for aggressive lymphomas. And the first, thing that I think that we've learned about aggressive lymphomas is that they're really not the same. That there are two major clinical classifications. There are probably many more than that, but two major clinical classifications of aggressive lymphomas. And I was wondering, Dr. Gordon, Leo, if you could talk to us about, I think that the risk assessment of DLBCL patients in 2016 beyond, again, clinical factors, but really thinking about the cell of origin and how that should shape our thinking about biology.
Right, and the way I think about this, and you can have two patients with large cell lymphoma, and you try and predict how people are going to do, and they can look the same clinically, they can look the same under the microscope, and for some reason one has a relapse within a few months, and one is cured, and they're being treated with the same thing. So we've evolved a number of ways to try and discern that. One is what you mentioned, the clinical features, and those are fairly obvious: more older, more disease, more symptoms. That's the International Prognostic Index. And then we tried to change that a little bit. The LDH level turns out to be, I think, a very important prognostic factor. We did a study years ago comparing CHOP and MBACOD and looked later at LDH, and LDH greater than 3 times normal had an outcome that was similar to what we saw in pancreatic cancer. I mean, it was just a very powerful prognostic factor, and that's where the NCCN, International Prognostic Index, ultimately came from. But even more than that, as we dig deeper, Lou Stout and Wyndham Wilson and their group began looking at genomics. Sandeep Dave also began looking at genomics and identified 2 major groups: the germinal center-derived diffuse large B-cell lymphoma and the activated B-cell or non-germinal center diffuse large B-cell lymphoma, with different pathways of activation and different genes that are mutated or important. And that becomes a fairly important prognostic or predictor. We know that the germinal center group does maybe a little bit better than the activated B-cell group, and we begin to think about different therapies for each of them, sort of in a little bit unexpectedly. As we dig even deeper, we're looking now at mutations of c-MYC. If that gene is mutated, you have activation of a variety of different factors, which makes the disease more aggressive. But of interest, most of the c-MYC activated, mutated patients occur in the germinal center group. So it's a little bit of a paradox in a way.
Yeah.
In a way. And we also have begun recognizing that you can look for the protein, c-MYC and also BCL2. If they're both mutated, then that's a so-called double-hit lymphoma. But if you look at the protein expression by immunohistochemistry, we think of those as double expressors, and those tend to fall into the activated B-cell category. And we're not sure yet what to do with those. We do know that ultimately we think we should be moving toward treating patients based on the cell of origin, germinal center versus activated B-cell, and even further on whether they're c-MYC mutated, BCL2 mutated or not. The problem we have is we don't know how to do that yet. We haven't identified a treatment that's specific for one versus the other, but we're beginning to do that. We're beginning to look at agents that might be more active in the pathway of activated B-cell and maybe more activated in the germinal center group, and it's something maybe that John wants to discuss.
Well, I think there are a few different approaches to this challenge. One is, as you alluded to, Leo, the drug or the intervention, and then it's the technique to identify that subset, whether it's immunohistochemistry. The nanostring group has one approach. There's obviously the more basic laboratory research-oriented approaches as well that have all to varying degrees been used in clinical trials to try to get after this issue. On the flip side, we have several drugs that have been used in this sort of strategy, the first being bortezomib, the second being lenalidomide, the third being ibrutinib, all of which have gone into randomized trials looking at one way or another identifying these populations and looking to see if adding the drug in that population makes a difference. So these are all, I would say that the jury is still out on a couple of these. One challenge is that the steps that lead to selecting a patient for a trial, meaning you see the patient, maybe it takes you some time to get their outside slides if you're a second opinion, the process of then performing whatever central assays that need to be done that may need to be sent out for the purposes of a trial. Those steps lead to a more favorable patient population, and that's something we observed in a negative bortezomib trial. There's an abstract at this meeting. Matt Maurer and the Mayo Group looked at very simply the patients who went from biopsy to starting treatment within 2 weeks versus the patients that went from biopsy to starting treatment after 2 weeks, and showed that that was a very important prognostic indicator, and the patients that waited had better prognostic features and actually had better outcomes. So just that simple step of having a patient wait, or on the flip side, patients that are able to wait have more favorable outcomes, largely presumably because they're walking in, they can wait, so they have better disease, so to speak. So that's going to be a key factor in all of this, and I think that's it may be or has already been for some of them a factor in the outcomes of these trials. Certainly in bortezomib, our data were consistent with that. So we have studies that looked at ibrutinib in this sort of fashion, identifying patients by cell of origin, and then randomizing the non-germinal center type as identified by immunohistochemistry to be able to then test ibrutinib in a randomized fashion more specifically in that population. And we have data with lenalidomide doing that as well. And those, the ibrutinib and lenalidomide studies are ongoing in various forms. Greg Nowakowski looked at the R-squared CHOP, or lenalidomide rituximab CHOP, and had some data in a variety of different analyses, largely retrospective comparisons, suggesting that the addition of lenalidomide could overcome that outcome, or the less favorable outcome of the non-germinal center type. But of course, that needs to be studied prospectively. So I think it's a great idea. I'm hopeful it will work. I'm a little bit cautious that it might not work because of these practical issues, but again, we'll have to see. So as of today, I don't think we should be treating patients on this basis, meaning getting your pathologist, our pathologist, give us cell of origin by immunohistochemistry, but generally speaking, we don't treat patients on that basis. And I think, as Leo alluded to, the key factors that in my practice, beyond clinical factors of the IPI, again, how much that changes therapy today is even debatable. Clinical factors like, does the patient have mediastinal involvement? Do they have testicular involvement, bone marrow involvement that might tweak my treatment a little bit? Or again, looking at the double hit group. Those are really the decision making rather than cell of origin at this point in time.